we at the Arthritis Foundation have really made DEI programming a priority for this year as well as next year, and we would like to see how we can grow our investments in a very strategic way by really supporting not just individual investigator-led initiatives, but a lot of collaborative initiatives, and really try to drive this multi-institutional collaboration that we had a few references to. And so with that in mind, we thought it would be good for us to have a panel discussion today to talk about some of existing collaborative models for DEI programs.
I'm going to turn it over and ask both Lisa and Alfredo to briefly, introduce their models and what they've been working on. And I know, Alfredo, you talked a bit before, but for folks who are newly joining us, a little bit of background. So maybe let's start with you and then to Lisa. And then if you could, after you talk a little bit about your models, tell us about some of the strategies that you use to help build and leverage support at your institution and sort of advocacy to be able to do and continue your work. So let me turn it over to Alfredo first for that.
Oh, okay. So our project is a collaboration between UNC Rheumatology and Piedmont Health Services, which is a federally funded organization that runs 12 community clinics throughout the state of North Carolina. And the goal of the project was to increase access to rheumatology care for underserved rural populations, and also provide a rheumatology education for community providers so they could manage at least some degree of patients with rheumatic disorders, and also has a component of education for our fellows to be exposed to caring for underserved populations. So fellows participate of the project, and it's done with a video telemedicine model where the rheumatologist, the attending and fellow, are in Chapel Hill at the university, and through video assist the primary care doctor who's on site with the patient in doing consultations for rheumatology care.
I'm muted. Apologies. Let me ask you one of the sort of second piece of the question, which is how maybe you can talk briefly before we turn it over to Lisa about how you were able to sort of leverage the support of your division and maybe your Department of Medicine institution to be able to do this project. I think I'm guessing that a number of people who are attending this session, myself included, would be so excited to develop a model similar to yours at our institution, and getting the institutional support is always challenging. So we'd love to hear about how you went about that.
So I guess we were fortunate enough that Piedmont Health and UNC have very strong ties already. Because a lot of our patients are referred by them from the different sites in the state. And also a lot of the providers there have faculty appointments at UNC. So that nexus there was already established, not specifically for rheumatology though. So what happened in my case was that is many of the patients I had evaluated, diagnosed, and then started on medicines could not continue to come for follow-up. So a couple years ago, two of the very energetic family medicine people from Piedmont Health approached me to see if I could do like sessions where they would present cases to me and help them manage these patients. And that's where the idea was, well, we need to make this more formal, right? And then the rest was, because you do want to have buy-in, right, from your leadership. And that was, in my case, it was surprisingly easy. Like my division chief was all over this, right?
Mhm.
And I think this is not new because UNC has this Center for Latino Health, which was a model for subspecialty care that I was part of, and was always supported by my division chiefs throughout the years for that. So, uh, and then the Department of Medicine and my division have a long-standing history of very committed to helping underserved populations. So it wasn't, that portion wasn't difficult. And what really helped was the enthusiasm and the willing to learn rheumatology from the Piedmont health providers, which is probably the hardest thing to find, right? Is
Mhm.
people who enjoy it, and these providers even do musculoskeletal ultrasound. So
Mm.
that's how it came about in a nutshell.
Awesome. Thank you. All right, Lisa, I'm going to turn it over to you. Tell us a little bit about the program that you've been developing and working on, and then sort of the second part, a little bit about how you forged your collaborations and garnered your institution support for what you do. Thank you.
Sure. Thanks, Candace. So I will talk more about my project in detail tomorrow, but it is basically a curriculum teaching project to try to teach medical students, residents, fellows about issues having to do with equity, inclusion, and diversity in rheumatology, and especially how health outcomes can be impacted among different groups, and that their care can be different. And so it's really a multimodal curricular intervention, a lot of which, honestly, I'm sort of going to mix the two questions, but a lot of it took advantage of collaborations and things that we already had ongoing at Duke, and really just kind of helped to broaden the topics. So, for example, one thing that one of my colleagues has been involved in, and I've been mentoring him in, is this project called Room Madness, which I will talk about tomorrow. But basically, as part of this project, he has been making a number of different podcasts talking about various different topics in rheumatology. And so what we did was we basically said every single podcast that we do is going to include a DEI focus as something that we specifically talk about as it relates to the topic. Whether we're talking about the issue of there not being enough diversity amongst rheumatology providers, or the issue of, how do you forge relationships with patients to try to ensure that they're getting the best care possible, how are outcomes different. We have a lot of folks on our faculty working on defining healthcare disparities. And I think kind of like how Dr. Fitzgerald talked about knee replacements being different among, between Black and white patients, things like even screening for cholesterol abnormalities and hypertension are different across Black and white patients. And so really just highlighting all of those differences during our podcasts. And then the second part took advantage of another collaboration that we had started a year or so ago, which was we created this online educational tool called RheumSim, RheumSim, and it was modeled after and collaborated with the NEFSIM people. And it's basically just online cases that are kind of at the medical student level about how do you diagnose, how do you evaluate rheumatic illnesses. And so the proposal was to create some cases that included a case of non-adherence because of medical poor healthcare literacy and numeracy, and then a case of a patient not reaching treat to target because of insurance issues. So I'll talk about this tomorrow, but being able to make a case like that you go through case like piece by piece online. Turned out to be like way harder than I thought it was going to be to do that. But at any rate, so that's one of the other things. And then, so that collaboration had started when one of the people there was a resident at Duke, and now she's a fellow in South Florida. And then the last one took advantage of a wonderful collaboration that Alfredo is very familiar with, which is the Carolinas Fellows collaboration, which is a long-standing educational partnership between the programs in North and South Carolina, along with Massachusetts General Hospital. And we have a winter program every year. And so what we decided was that during the winter program that started off at Duke last year, we really highlighted some of the work that we've been doing on looking at medication adherence in our lupus clinic population, and those differences are very pronounced by race. And then our plan for this winter conference, which will happen at UNC in a few months, is to work a little bit more with the fellows on how do you address this as a single individual at a large institution moving forward. And then, the last part, which has proven to be very hard, way harder than I anticipated. I thought this would be the easiest part of the project, was having a visiting medical student rotation in adult and pediatric rheumatology for students from underrepresented in medicine backgrounds. We have yet to have a student enroll, and I think part of that was, honestly, I had communicated with the Arthritis Foundation folks. I think some of that was the timing of the grant versus the timing of when medical students sign up for their fourth-year electives. So we're working right now on a really big push to advertise through LMSA and SNMA to try to find that. And there's been a variety of other challenges there, but I don't need to go into those in great detail.
Awesome, thank you. So Alfredo, I believe that this question in the Q&A is for you from Dr. Gilbert. If the PCP bills for the encounter, where does the funding come from for the rheumatologist effort in an RVU system?
Yeah, well, so far it's just goodwill, I would say, from my division chief, that basically it's my time that I use. So I'm using my admin day for that right now. And as I was assured that for long term, because if we are unable to, once this funding ends, what to do next, right? We're going to try to get external grants to continue it, but I was assured this week, actually, that even if we don't get outside funding or any type of funding, we'll continue the program. And it's probably we won't be able to expand it as much, but at least my portion of it will continue.
That's great. There was a follow-up question about thinking about funding from the Office of Minority Health as well, Alfredo, for your work. I'll ask Lisa actually the same question, which is about sustainability of some of the initiatives that you've been talking about. And I think that's always sort of in the back of our mind as we think about these programs of, these grants are 1 year, maybe 2 years. And,
right.
A lot of it is building infrastructure, but the question is sort of how do you sustain it thereafter? Is it reliant on additional grants? Is it through institutional funds, et cetera?
Yeah. I think that the podcasts are something that David is doing every year. And to be really honest with you, one of the things that we've focused really hard on at Duke is that every single thing we do in education has to be done with a DEI lens. Like every time we do anything, you have to consciously ask yourself, am I being inclusive? Am I, trying to promote diversity? Are we providing equity of opportunity, equity of experiences, et cetera, for everybody? So it may not be that the podcasts go on forever, but I think that really trying to make it a habit to focus on thinking about EDI issues is really one of the most important things that we can do. And so, the room sim cases, I'm going to make the room sim cases. We'll see what the uptake is on them. I will be able to use them with medical students. We'll use them in our med student rotation. So they'll keep lasting here, and we'll keep trying to advertise them. But there's a lot of other things that we're doing to just really incorporate this all the time. And I'd be happy to share some of what we're doing, even in our fellowship application and recruitment process, and things that we're doing in the Department of Medicine for recruitment to just really focus on these issues and remembering that it's important to think about diversity and equity and inclusion every single day. Not just with a project.
Yeah, absolutely.
That's great. I have another question. I have one question here. I'll sneak mine in before this next one, just because it stems from what you both have been saying. And I was curious about what you both were using for your respective projects as metrics for success, and how you're measuring impact. Maybe Alfredo, I'll start with you.
Okay, so the first stage, I would say, of our project, it's more qualitative, and we're looking at using surveys that we give patients after each visit to get data on their satisfaction with the visits, with the virtual platform, and also to see if it saves them time, if it's especially in traveling, and if they want to continue with that modality. Then we also have been collecting data via surveys from the Piedmont Health providers for the didactic sessions, and also trying to measure how comfortable they feel managing rheumatic disorders, and with their general knowledge about rheumatology. And then the providers that we surveyed, the providers who participate of the clinics after each visit. So that's the first data we collected. We also collected self-reported patient demographics that I presented earlier today. For a second phase, we plan to be a little more in-depth, and use more quantitative modality combined with qualitative methods like structured interviews, where we'll interview Piedmont Health providers and patients, and try to get other metrics, for example, time to the initial visit, cost of the visits for the patients, time to starting a DMARD, time to the initial diagnosis. Also, the idea is to train the providers to use the treat to target validated tools like CDI, and measure that to see a little bit what the outcomes are, among several other metrics we're considering.
That's wonderful. That's great. Lisa, same question for you. A little bit different context, I know.
I mean, our outcomes, the outcomes measure in creating a curriculum is a little bit different. It's, did we successfully create the curriculum? And we're just about there. But really, I think it's about uptake and, listening. And so we have lots of data for the podcasts about how many people listened. And it was part of a bigger project that David Leverins, one of my partners, is doing, where he actually did some community of inquiry surveys to judge engagement with the project and engagement in a learning community for that, which is, not specifically related to the DEI component, but one would hope that having that as a component would make people feel more engaged and included. And then again, for like an online thing, it's really engagement and uptake in it. I think ultimately some of what we're going to find out is really going to be about our trainees' comfort with addressing issues of inequity in healthcare and in unequal access, et cetera. There are a lot of ways to measure it. That is not a planned part of this project for me right now, but as I'm listening to Alfredo, I'm thinking, wow, it'd be really great to do a qualitative study of your trainees who are collaborating on this with you about how they feel in terms of their ability to manage patients in this particular way, and you know, the underserved population, and how this experience is impacting them. But you know, and then of course our hope, once we get our students to come visit at Duke and do a rotation, the hope of course is that they will become rheumatologists. But we're not going to know that for a few more years. And then, you know, of course, you always hope when you have medical students come and visit that there are people who eventually could be part of your faculty, right? Like it's a recruitment strategy. So I don't have outcomes for that, but you know, certainly we will be following these individuals.
I would say, Lisa, let's do it.
Let's do it. Let's talk afterward.
That's awesome.
Maybe we could do both institutions, and then we can work with all the trainees on it.
That's great. I think I have one question in the chat from for Alfredo here. This is regarding funding, and there was a question about whether you were billing joint telemedicine visits, noting that this is something that Dr. Hughes mentions that they do at the University of Washington. And he also wanted to know if participating primary care docs get CME credit for didactics.
Yeah, so no, I don't bill for this. So from our end, we don't bill. So patients are billed only for their visit at Piedmont. And then in terms of CME, since it's a pilot, we had not thought about that. I was thinking about that this morning. That would be nice. I know that's done in Colorado, I think, with the Project Echo, where PCPs can get CME credits for their sessions. So I think if this takes and we can continue it, definitely we should be able to provide CME credits for the sessions. Yep.
That's great. And there's another question here that's posed both to Alfredo and Lisa, which is, do either of you have information about new or strengthened DEI related quality improvement curricular requirements in forthcoming ACGME adult rheumatology program requirements?
So the official ACGME requirements are not that specific, right? The ACGME program requirements do require that every program teach quality improvement. I am not aware, and I'm going to potentially punt this to one of the other panelists, but in terms of specific ACGME requirements regarding teaching DEI as it pertains to QI, I don't think that is there or is going to be a part of it. You know, the ACR curriculum subcommittee has worked a lot on creating and adapting the recommended rheumatology curriculum for training programs. You know, so that a couple of years ago, we added some curricular information about doing telemedicine, for example. And I remember us having discussions about DEI as well into some of the competencies that fellows should be learning. I hate to put people on the spot, but Sharon Dowell is on as a panelist, and she took over from me as the chair of the committee, and I'm not sure where that work is now. They've been working on a lot of different things, but it's a great question, and it's something that I think people have to keep in mind. I'm not sure that there's going to be humongous national requirements on it, aside from an awareness and something that people, you know, talk about and encourage.
I will say I did some very quick Googling as while this came up,
Googling,
and did identify that in a set of common program requirements that looks like it came out in February of this year, there is a statement here that says the mission of institutions participating in graduate medical education is to improve the health of the public. Each community has health needs that vary based on location and demographics. Programs must understand the social determinants of health of the populations they serve and incorporate them in the design and implementation of the program curriculum, with the ultimate goal of addressing these needs and health disparities. So I don't, you know, and that's it says here, the ACGME program requirements for graduate medical education in rheumatology. And it looks like it was approved February 7, 2022, effective July 1.
Yeah.
I will go ahead and put this in the chat for everybody in case this document is of interest to folks. So it sounds like, as Lisa said, it is not particularly specific or prescriptive, right, but it does recognize the importance of incorporating social determinants of health and awareness of the populations that are being treated and their social needs as well, which I think is important, and recognizing that our fellows need to be trained in those issues in order to provide the best care to their patients. So, all right. Well, maybe we have a little bit of time left, so I had a couple of additional questions if I don't see additional ones in the chat. And, one question that I had is thinking about people who are attending this session and thinking about developing programs like yours at their respective institutions, and thinking about, what resources may be available to them, both, content-wise and education-wise, and also other funding opportunities and the like. And, how, both of you clearly have, well-established networks within your institutions that you've been able to leverage to do the work that you're doing. For people who may be more junior, how do you recommend somebody kind of get started doing work like this at their institution? Maybe I'll start with Lisa for this one.
Sure. I think we're incredibly lucky in rheumatology in that rheumatology is such a small world and everybody is so nice. So, we really are fortunate that there is an amazing network of program directors and of educators, right? So the ACR has been well ahead of other subspecialty organizations or specialty organizations in having had a rheumatology program directors retreat every year for more than 15 years. So that all the program directors in the country have gotten to know each other. And now with the addition of the education exchange, which they really are focusing on all educators, there is just a huge network of people. If anybody wants to collaborate on any kind of educational intervention that can be used across the board, there are many people ready, willing, and able to collaborate. And I get emails from people all around the country all the time asking to share curricula that they have heard that I've made, or vice versa. And people are very, very interested in doing that. And I think probably the one silver lining of COVID from an educational standpoint is that we've all gotten very used to collaborating and doing things over Zoom. And, we have had faculty members from around the country give our core curriculum to our fellows about various issues that they might have expertise on that we don't have expertise on. So I think from an education standpoint, it is really wide open to be able to collaborate with people all over the place and create interventions.
Great. Alfredo.
Well, I agree with Lisa 100%. I think so caring for minorities, there's no escaping that, right? It's there, and in most institutions, I think it's people, you're gonna find people or mentors of people who are doing it all over the country. I think in our division, or UNC, that I know there's a good structure coming down from the dean's office and the School of Medicine and Department of Medicine. And we do have a DEI champion and a director of DEI in our own division now for several years. It's Dr. Iwala. And so there's, I think, having someone like that in your division can help you identify mentors in projects or develop projects. We have a working group in the division that meets 6 times a year and comes up with different initiatives. Fellows participate of that. There's a DEI journal club. Fellows participate of projects and give grand rounds on DEI, and we have DEI experts give grand rounds as well. So I guess networking within your division, it's the best way. If you have a DEI champion, of course, it will help.
That's great. I was going to another question that I was going to ask both of you that you've answered, and I was going to pose to Lisa as well, which is, I know a lot of the efforts that we think about are dedicated to medical students and residents and fellows, but I say as a faculty member, I have plenty I still need to learn, and our faculty constantly loves learning and thinking about these things. And it sounds like, as Alfredo was saying, having grand rounds and external speakers is one of the ways that, or making sure that education is sort of on all sides around these issues with this sort of equity first lens that Lisa, you mentioned too. I was curious if you, speaking as an educator, have done work too to sort of think about how we can continue the education of our faculty to better support, the same goals that we all have.
Yeah, I think that's a great question. And sometimes we as faculty get left a little bit behind, right? Because we're teaching everything new to the people who are coming through. But I can give one example of something that we've done at Duke. I'm just pulling up an email because I pulled it up ahead of time. So, as part of our recruitment strategy for Duke for rheumatology a couple of years ago, David Leverins, who's now the program director, but when he was APD, we came up with this kind of set email and way that we think about doing holistic application review, where we identified kind of the four characteristics that we think are most important to be a successful fellow in our program. And we wrote those out explicitly. And then we have an email that we send the day before interviews every single time to all of our faculty that tells them, all the things you can't ask. But it basically, it talks about sort of put your biases away. And we have a whole section in the email about equity and implicit bias. And we say, please sit down for 1 minute right now and reflect on yourself, and to ensure that we have a holistic and equitable review of our applicants. And say, take 1 minute right now to reflect on your own experiences in academic medicine. We often favor applicants who are like us. This does not just refer to race, ethnicity, and gender. It also applies to life experiences. For example, many of us went straight from undergrad to med school. This could bias our view of non-traditional applicants who have different life experiences. In what way could your own training and experiences experience your evaluation of applicants? And then we say, acknowledge common factors that unconsciously influence our perception of applicants. Examples include physical attributes, weight, and the extent to which the applicant's personality matches your own. We all have unconscious biases and other blind spots. Reflecting on them is crucial for equitable assessments. And then we say, reflect on our characteristics of our ideal applicant. These definitions help us avoid the trap of focusing on an applicant's fit within our program, which can increase the risk of bias. Our list of ideal characteristics are included, etc. So, that's something that we do for all of our faculty members who are going to be interviewing fellowship applicants. Likewise, now in my position as vice chair, I send out during recruitment season, I am constantly sending out notes to faculty to remind them about implicit bias. And we offer a number of implicit bias training sessions, often modeled on the Harvard implicit bias training as well, to just, to try to have people think about, if we want to increase diversity, especially among providers in rheumatology, we have to really be conscious about what our biases are and looking at every applicant holistically. And it makes us reflect as an institution on what is it that we value and who do we think are successful in our fellowship program, and how do we find those people, as opposed to, the typical people who might be easy for us to talk to or get along with because they are like us. So those are just a few different things that we can do for faculty. Sorry to have taken a lot of time to read that, but I'm really proud of what we put together there.
Awesome. How has it been received, out of curiosity?
Really well.
Awesome.
Really, really well. And I think it's actually helped us to be much more focused on having good discussions about what candidates, would be best for our program, and that we've got a we've also been very careful to balance when we're determining who we're going to invite for interviews, and think about that, and think about various goals of our program and ways that we want to grow our faculty. So I think it's been good. Nobody seems offended by it. I guess if they are offended, they haven't told me, but everyone seems actually very excited by it.
That's great. I was thinking about the keynote talk we had today too, and I think one of the things that was mentioned there was having sort of a second look and a sort of fellowship or second look revisit for URM applicants, and thinking about that piece as well. I was curious, is that something you've implemented? I know that happens at our institution now as well.
Yep. We had wanted to do it for a number of years, but kind of couldn't figure out how to do it with in-person visits. And that was another thing that as soon as COVID happened, that we started a virtual second look for fellowships. And so we just had that event last week. And it was a collaboration between the Duke Department of Medicine and Department of Pediatrics and the DEI office in PEDS and our Minority Recruitment and Retention Committee. And we had our fellowship second look across all the specialties. So I think it's important.
That's great. Yeah, I was thinking, I think, we have maybe time for one more topic, and that was, both of you have sort of alluded to collaborations and sort of conversations across subspecialties in the Department of Medicine. And I think one of the things that our vice chair of DEI for our Department of Medicine here at the Brigham has initiated is a diversity council meeting I believe it's every 1 to 2 months, where each division chief is required to attend in addition to the DEI task force leader for each of the different divisions. And the idea is to sort of formally set metrics, discuss strategies, talk about potential challenges, and think about, what is something that, division, the cardiology division is doing that the rheumatology division could learn from. And is there something that some strategy or some sort of set of programming or educational curricula or something that has been working well and developed in a different subspecialty that can then be adapted beyond that? And then also thinking about what kind of institution-wide mechanisms can be put in place Department of Medicine wide to help all of the different divisions meet their goals as well with this equity first lens, and also to improve diversity in our field, which is much needed. So that's something our institution is doing, which I think has been, at least for me, extremely valuable. And I've picked up many tips from other divisions who have been doing great things too, and have led to different collaborations. And I'm curious if there are similar type things at your respective institutions.
Yeah, so I don't participate of the interdivisional meetings, so I'm part of our working group inside the division. But there's a whole structure at UNC from the School of Medicine. There's the vice dean who meets quarterly with the different department heads, Department of Medicine, Surgery, and others, the hospitalists as well, and they coordinate efforts there. And then the Department of Medicine, there's the vice chair of DEI who meets every month with each division's DEI champion and director, and they report back to that person. So there's a change of command, and where efforts can be coordinated. Yes.
Yeah. Sounds like maybe a lot of places have something similar. We have every division in the Department of Medicine has a vice chief for DEI, and then across the department, we have what's called the DARE committee, DEIAR, the Diversity, Equity, Inclusion, and Anti-Racism Committee, where we gather frequently to share, and then we have different working groups on clinical education, etc.
Wonderful. Well, thank you. I want to thank our two wonderful panelists. We are perfectly on time, so I'm grateful for that, and wonderful discussion. And we really appreciate all of your insight and guidance and the wonderful work you're doing at your institutions. And we look forward to continuing to learn from you both, and Lisa, to hearing your talk tomorrow as well. So thank you.